All right, I'm happy to announce that we're going to go ahead and get started. Hello, welcome, good morning. Good morning, everybody. Let me ask that you please take your seats. And I'm very, very happy to welcome you today to our event. I am Cecilia Oregon. I'm the Executive Director of Kaiser Permanente's Institute for Health Policy, and thrilled to be able to welcome you today. At the Institute, we host events and publish information to shape policy and practice on important health topics. We convene experts to share knowledge, spark discourse, advance collective thinking, and explore opportunities to cultivate healthy communities and promote accessible, high-quality care. We're excited to co-host this conversation today in partnership with Kaiser Permanente's School of Medicine and the National Academies of Sciences, Engineering, and Medicine on a critically important topic addressing racial and ethnic inequities in health and healthcare. This event is the result of a lunch a few months ago with Dr. Fate and Cheryl Nass from the National Academies, and I am so happy that we've been able to bring this event together. Especially also with our colleagues from the School of Medicine, EJ and Lori. Thank you for your help with this. I also want to acknowledge that we have some members of congressional office potentially and some assembly members' offices represented. So Assembly Member Mike Gibson's office, Assembly Member Laura Friedman, Assemblymember Avelino Valencia, and Senator Newman have representatives in the room. We're happy to have you here, as well as HHS Region 9 representation. So before we get started, I am going to go over a few housekeeping items. We are recording this event, so I'd like to ask that you please silence your phones. If you have to take a call, please do so outside, and you can ask staff if there's a room available if you need a little privacy. For the Wi-Fi access, please connect to Kaiser Guest Network and accept the terms and conditions on your browser. And all the information that you need about today's event can be found on the QR code, through the QR code you received at check-in. So this will include the agenda, speakers' bios, and other information about today's event, and on the Unequal Treatment report itself. It will also include a survey for feedback, so we really do look forward to hearing your feedback on how today went. To access the restrooms, please turn right as you exit the room and then go straight down the hallway in front of you. If anyone needs a mother's room, please ask one of our staff members and we can help direct you. And if for any reason we need to evacuate today, if there's an emergency, please note the emergency exits in the sliding glass door to the right. At the end of the session, there will be time for question and answers, so please have those prepared, and we'll aim to include as many questions as possible. Now, I want to turn it to our co-sponsors, and let me introduce you to Dr. Dalrymple, the Dean of Kaiser Permanente School of Medicine. Thank you.
Thank you, Cecilia. And good morning, everyone, and a hearty welcome to the Kaiser Permanente Bernard J. Tyson School of Medicine. We're very excited to be hosting this amazing event here today. And for those of you who I haven't yet met, my name is John Dalrymple, and I'm the Dean and CEO of Kaiser Permanente School of Medicine, and I have been in my role for 3 months, so I'm still settling in. Thank you. Prior to joining KPSOM, I was most recently at Harvard Medical School as the Senior Associate Dean for Medical Education and the Ellen and Melvin Gordon Professor of Obstetrics, Gynecology, and Reproductive Biology and Medical Education, as well as the Executive Vice Chair in the Department of OBGYN at Beth Israel. I've been involved in medical education leadership for over 2.5 decades, and I've had the good fortune of being at many institutions, including UC Davis up the road in Sacramento, as well as back in my home state of Texas at University of Texas, Houston, and the New Dale Medical School prior to going back to Harvard Medical School. And I have to say, it has been absolutely invigorating being a part of medical education, especially at such an innovative school like KPSOM, where we are addressing many of the issues that we're going to be discussing today. I do also want to welcome you to this vibrant medical education building. This school is just a little over 4 years old, and hopefully you can see what a beautiful structure it is. Very innovative space. Even this room that we're in is meant to allow us to provide any way of delivering our innovative curriculum in many different formats. And hopefully you've been able to wander around, maybe get up to the rooftop deck, which is a really beautiful, airy space that is focused on well-being for our students, faculty, and staff. And hopefully during the break or after lunch, you can wander around and enjoy all the beautiful places that we've created here. When Associate Dean for Community Engagement and Government Affairs, Dr. Lori Carter-Edwards presented the possibility of hosting this event at our school, it was really a no-brainer. First of all, the National Academies of Sciences, Engineering, and Medicine is one of the most respected institutions in the field of medicine and includes some of the most keen and innovative minds in the country. Secondly, our Kaiser Permanente Institute for Health Policy, which is focused on influencing policy and practice with evidence and experience, aligns with what we're all about. And as a school, we are devoted to training courageous leaders of change within the profession and in society. And we deeply respect and honor the value of evidence-based dialogue in these areas. And finally, the report itself, Ending Unequal Treatment, focused on closing racial and ethnic disparities in health and healthcare, is one that speaks profoundly to our values and commitment at this institution. Here at KPSOM, we are an institution that lives and breathes equity, inclusion, and diversity, that seeks to understand history, structural inequities, and the challenges of the present, and that is focused on training the future physician leaders that we need to grapple with these issues and make meaningful differences in the health of all of our communities. So thank you again for choosing to host this event on the West Coast at our school. We're delighted to have you all here, and we can't wait to hear the panel. And with that, I'd like to turn it over to Dr. Monica Feit, the Executive Director for the Health and Medicine Division of the National Academies of Sciences, Engineering, and Medicine. Thank you.
Well, I've managed to break this. Hold on. There we go. Is that right? Yeah. Okay, that might be better. Thank you. Thank you. Hi, I am Monica Feit. I am the Executive Director of the Health and Medicine Division, and I want to thank our partners today for making this event happen. It's very exciting, and I'm really excited to be here. So the National Academy of Sciences, Engineering, and Medicine is a very broad group, but the Health and Medicine Division is the programmatic unit within the National Academies that really focuses on health and medicine activities. We've been around since 1863, and our charter stipulated that we would provide advice to policymakers and the nation drawing on evidence and science. And so we do that in a number of different ways. We assemble a range of perspectives to highlight emerging science in public meetings. We convene interested parties to focus on pressing topics in an ongoing and systematic way. We harness expertise to rapidly respond to critical questions. And then we produce our gold standard, which are consensus studies. And today's discussion centers around our recent consensus report, Ending Unequal Treatment. Like all of our consensus studies, it was written by a committee of experts who brought a range of expertise, viewpoints, and perspectives. They reviewed the published literature, they conducted public information gathering sessions, and then they ultimately wrote a report that was subjected to our rigorous external review process. So no easy feat. And a big thank you to those of you who are here today who did that. This report was published by the National Academies in June of this year, and it builds on the 2003 Institute of Medicine report, Unequal Treatment, which documented the disparities in the quality of health care received by racially and ethnically minoritized populations persist even after accounting for socioeconomic conditions. The 2003 report also made several recommendations to improve the clinical encounter to address these healthcare disparities. 20 years later, inequities still persist. So with support from the Agency for Healthcare Research and Quality and the National Institutes of Health, the National Academies convened another expert committee, some of whom are with us today, to revisit this problem. The committee was tasked with reviewing the major drivers of healthcare inequities, providing insight into successful and unsuccessful interventions, identifying gaps in the evidence base, proposing strategies to close those gaps, and making recommendations to advance health equity. I'm looking forward to the discussion as they share some of the findings and recommendations with you, and as we all discuss how to advance this important work moving forward. It's going to be an exciting day. Ceci?
Thank you. Now it's my pleasure to introduce Dr. Andy Bindman. He is our Executive Vice President and Chief Medical Officer for Kaiser Permanente. He's responsible for driving superior quality and equitable health outcomes through the integration of quality innovation, care delivery, and research in collaboration with the Permanente medical groups. Dr. Bindman will come up and introduce our speakers as well.
Well, thank you, Ceci, and what a pleasure to be here today. I was going to say it was both a pleasure to see you again, Monica, and also to learn how to lower the microphone. That was very helpful for me. So what a pleasure to be with you all today, and welcome, and thank you all for joining us today at the Kaiser Permanente School of Medicine. Kaiser Permanente was eager to host this event and facilitate this important conversation in alignment with our commitment to reliably deliver the highest quality care for all and to eliminate health inequities. As Monica referenced, it was more than 20 years ago that the landmark Unequal Treatment report was not only one of the first, but probably one of the, maybe the most influential reports to address and examine causes of health disparities, including racism in healthcare. In the 2 decades that have passed, much has changed in how we think about mitigating health disparities. We certainly have learned that, and we know now that equal treatment is not enough. As part of the process of developing this report, I had the great privilege, at the invitation of the National Academy of Medicine, of speaking to the committee. And I shared that at Kaiser Permanente, we believe that equitable care does not simply mean making the same services available to all. It's about providing all the care that is needed to maximize each individual's health potential. Like other healthcare systems across the United States, we're still working to mitigate racial and ethnic inequities in our healthcare system. We take a two-pronged approach by implementing systematic, evidence-based approaches to care that mitigate individual biases, and by focusing quality measurement on health outcomes examined through the lens of equity and accounting for the social health factors that contribute to differences in outcomes. Our focus on both process and outcome measures demonstrates how we hold ourselves accountable for both equal treatment and equity. Our value-based model is especially well-positioned to implement these practices because our technology-supported coordinated system that's rooted in a robust electronic health record. But we know that not all health systems benefit from this type of coordinated care model that we have, and that we and the rest of the healthcare system have much work to do together to reach a more equitable future state. Today, we will discuss what we've learned and what's changed over the past 20 years, and how we turn those learnings into action as we look ahead. So I'm now going to have the pleasure, and please welcome up to the panel our esteemed panel guests, and I'll take a moment to introduce you all. So please take a chair up front here. I'm going to first, I'm going to introduce all of the members of the panel, and then they will take turns coming to the microphone to make some comments, and then afterwards we'll have a moment to have a panel discussion. So let me first introduce, at the far end, Dr. Georges Benjamin, who has been the Executive Director of the American Public Health Association since 2002. From his firsthand experience as a physician, he knows what happens when preventive care is not available and when the healthy choice is not the easy choice. He is leading the association's push to make America the healthiest nation on earth. We also have Dr. Elaine Batchlor, who is the CEO of Martin Luther King Community Healthcare, a CMS 5-star rated hospital and health system that provides a high-quality care to 1.3 million residents of the medically underserved community of South Los Angeles. Dr. Batchlor has devoted her career to reducing health disparities and expanding healthcare quality and access for the most vulnerable. We also have Dr. Vincent Guillermo Ramos, who is the Executive Director of the Institute for Policy Solutions, a distinguished professor at the Johns Hopkins School of Nursing, and the founding director of the Center for Latino Adolescent and Family Health. Dr. Guillermo Ramos is a nurse practitioner, duly licensed in adult health and psychiatric mental health nursing. And then finally, Dr. Tucker-Seeley is the principal and owner of Health Equity Strategies and Solutions, a consulting firm that advises health organizations, departments, committees, and coalitions on addressing social determinants of health, defining, measuring, and intervening on health disparities, and health equity strategy development, implementation, and evaluation. Now, you can read more about each of these individuals and their backgrounds. Some information is provided on the website through the QR code you received when you arrived today. I want to emphasize each of these panelists contributed to the committee and the report that we're talking about today, so they have a firsthand experience they can provide. They're going to provide some comments here at the podium, and then we'll have a discussion as a group. So first, I want to welcome Dr. Benjamin.
Thank you very much, Dr. Byman. Let me say that 20 years ago, when the original report was done, the then Institute of Medicine did a couple things. That report focused a lot on saying if access to care and many of the other attributes of care delivery were the same, would you still have health inequities? And that's an important differentiation from our study. Our study really isn't just a do-over. We just didn't look at what happened 20 years ago and use the same parameters of what they did at that time. What was groundbreaking at the time was they basically said that disparities occur in healthcare and that there are biases that we as clinicians and the system bring into that equation to make a difference. And also, for the first time, very definitively talked about the importance of the social determinants of health as a component of trying to improve health. You notice that our title is called Ending Unequal Treatment. We wanted to be definitive about that. And strategies to achieve equitable health care and optimal health. Notice that we didn't say health care. We talked about achieving optimal health. So our committee took a different tack to approaching this challenge, and in many ways try to do a bigger look at the problem in our system. So I have the obligatory disclosure that I don't have any, at least, financial biases. And of course, as you heard from Monica, the NIH and ARC fundamentally funded the study, and that the National Academy of Medicine's Kellogg Health of the Public Fund is paying for a fair amount of the dissemination. When I think about health inequities, I really try to look at these four buckets, that there are differences in health care access. That doesn't just mean having an insurance card. That means actually being able to use that card in a meaningful way. It means having providers and facilities and all the things that you need to actually get the care that you need. Variances in the quality of care received within the healthcare sector. Differences in health-seeking behavior and of course the all-impressive social determinants that influence health, and that includes racism and discrimination at all levels, by race, ethnicity, gender, sexual orientation, sexual identity, however you want to look at the various things in our society that we know either allow you to be healthy or impede your ability to be healthy. I think one of the most important part of our study was that, and that's not to take away from all the amazing researchers that have been involved in this process over the years, we've had tremendous improvements in certain parts of the care delivery system and health outcomes in our system. But when you look at the sum, we've really made little progress in actually advancing healthcare equity overall. And at the end of the day, as they say, every system is perfectly designed to give you the outcome that you get. It's the system. It's the system stupid. No doubt about that. The system is designed to give us inequities. And we can talk a little bit about that, but differences in access to care. We still have about 10 states, I think, that have not expanded Medicaid and therefore don't have conceptually universal access to health care in their states. We pay differentially for states. When I was practicing medicine and both a city and a state health commissioner, we struggled to get providers to maintain our Medicaid program, say as Medicaid providers. Now we're having challenges getting people to be maintained as Medicare providers in our system. The pay differentials that we've crafted in this system have now become a barrier. The way we pay for care, many of the systems we've developed, the private equity investments, which can be positive and negative in our system. Our system is designed to give us the outcomes that we are getting, and we need to understand that and then fix some of those things. All in all, we still believe it's a feasible goal. And more importantly, because this issue continues to come up, if I get mine, then you won't get yours in this country. That's a really big issue. And this is not a zero-sum game. We are all in this together. If we take care of the people that need to be cared for with the most need, everybody benefits. Let me say that again. If we take care of the people with the most need, everybody benefits. This is not a zero-sum game at all. And we need to continue to beat that drum each and every day, because there are forces out there that would like to dissuade us from this conversation, raise red herrings in the conversation by saying, I can't take care of these folks with severe needs because I won't get my care taken care of. That is not true, not at all. So we've had some of our conclusions. I'm going to run through these really quickly. We've obviously had lots of changes in laws and policies that have implications for access, quality, affordability. The Affordable Care Act still is the landmark change that we've had. These changes have clearly advanced health equity in a significant way, but some of them have slowed down progress. Some of the things that were in the ACA were never implemented or never funded. So what was great that we had a nice blueprint and we actually have a lot of stuff still on the books, we've pulled back on a lot of that stuff. That certainly would have made a difference. Certainly that our system, one of its flaws is that we still, while we have a continuum of care, we still spend, and I'm an ER doc, I understand this, and it's painful to understand that 80% of what makes you healthy occurs outside the doctor's office, and the failure in primary care is our fundamental flaw. We just don't invest enough in the front end of the system. Every other industrialized nation does so. Got everybody in the system, and they focus a lot on basic, comprehensive primary care, including mental health care. We don't do that as part of our problem. And then, we love pilots. We pilot everything. We study this and we pilot that. And these time-limited and incremental reforms often fall short of improving healthcare equity. They often, trigger unintended consequences that widen inequity gaps. Anybody doesn't believe that, let me take you back 4 years. We had this challenge in our nation, in fact, this challenge in our world called COVID. It started out poorly. if you think about it, we actually built a universal access single-payer system to function on COVID. As a nation, we focused on messaging, on dealing with misinformation. We were able to close vaccine gaps. We had tragically lost over 1 million people overall, but that was less than we would have lost had we not done what we did. And yet, then, of course, when the emergency went away, where did we go? We went back to the old system. And what are we now seeing? We're seeing those gaps return. And in some cases, the gaps are widening. You know, we obviously need more research and evaluation to really understand exactly what some of these things are going to do. But one of our real fears is that we don't widely disseminate these findings as rapidly as we can, and we don't scale up interventions. You know, it takes 7 years at minimum for a new intervention to get into our system and really become normalized as part of the process, and yet something we really, really know works, and we don't do that very well. And then accountability. Accountability remains our big issue. You'll see in our study, we focused on a few of these things, like some of the civil rights laws that are on the books that we haven't implemented fully or haven't funded to the extent that they need to be funded. But accountability, oversight, is a big issue and a failure of our system. We seem to have this failure to really want to hold people accountable and hold the system accountable, and in many cases hold ourselves accountable for the kinds of outcomes and care that we know we absolutely need in our system. So I think that's the last of my slides, and I'll thank you, and go to Dr. Batchlor.
Hello, everyone. Oh, I guess I have to turn on the speaker. Hello, everyone. Can you hear me? Okay, it's a pleasure to be here with you today. I am the CEO of MLK Community Healthcare, which is a hospital and healthcare system in South Los Angeles, and one of the few non-academic members of the Unequal Treatment Report group. And I'm going to talk for a few minutes about the real world and try to draw a connection between the findings and recommendations that we put into the Unequal Treatment Report and what health inequities look like in South Los Angeles. They asked me to talk about this from the perspective of someone who witnesses health disparities every day, to talk about the root causes of those disparities, and about the urgency of addressing them now. That is actually pretty easy for me to do because I work and lead a health system that is located in an underserved community and that is exemplary of the types of inequities that we're talking about in the Unequal Treatment Report. My health system serves the historically under-resourced communities of South Los Angeles. It's a place with the types of systemic and structural inequities, broad social deficits, and inadequate healthcare infrastructure that we wrote about in Unequal Treatment. Oops. This is a map of 1939 Los Angeles. It was meticulously created to show areas that were desirable for real estate investment. Those areas are in green and in blue, and areas that were considered undesirable for investment. Those areas are in red and to some extent in yellow. These were areas that were redlined, that were not eligible for real estate loans. Because of housing covenants and other restrictions, African Americans and other people of color living in Los Angeles were unable to buy homes in most of Los Angeles County. South Los Angeles was one of the few places they could live. And as a result, over time, South Los Angeles became a community of color and concentrated poverty. It became a place that lacked investment in the types of health-promoting infrastructure that we all take for granted in our communities. Physical safety, quality schools, recreational areas, grocery stores, and healthcare. Today, South Los Angeles remains a community of color, a community of poverty, and a place where the majority of residents depend on public insurance, mostly Medicaid, for access to health care. This is also South Los Angeles in 2023. It's a place with high rates of chronic illness and a 10-year shorter life expectancy than the rest of California. A lack of access to health care contributed to the Watts riots that occurred there in 1965, and a lack of health care infrastructure has persisted to this day. Due to the lack of access to community-based care, my small community hospital operates one of the busiest emergency departments in the country. As you can see from the slide here, diabetic amputations and wounds are the most frequent surgical procedures we conduct at our hospital, a testament to the lack of care in the surrounding community. And if you're wondering why there is so little care in the community, why there are so few hospital beds, and why there are so few physicians, the story is told right here on this slide. These are the actual payments we received for emergency department visits last year. And as you can see, historic patterns of deprivation are perpetuated and maintained by an insurance system that pays providers less for treating Medicaid patients and less than the cost of care. My health system loses millions of dollars a year on emergency department visits, while at the same time, for-profit Medicaid health plans are paid by the state to provide access to their members. Unfortunately, they aren't getting the access they need. This slide is a result of a recent study that we've been conducting with UCLA Center for Health Policy Research that is looking at ambulatory care-sensitive conditions across Los Angeles County. Ambulatory care-sensitive conditions are conditions that can be easily treated in a doctor's office or in an urgent care and should never result in emergency department visits and hospitalizations. On these two charts, you can see that there are two geographic outliers in Los Angeles County. The biggest outlier is South Los Angeles, and the second is the Antelope Valley, where they have very high rates of ambulatory care-sensitive emergency department visits and hospitalizations, a reflection, again, of the lack of access to community-based care. And this brings me to the recommendation that we made in Unequal Treatment to eliminate inequities in healthcare coverage, access, and quality. Hopefully you understand what we mean by inequities, having seen the previous slides. We would like for there to be equitable insurance coverage for patients who live in under-resourced communities. And to get there, we need the insurance program that covers many of them, Medicaid, to at least achieve parity with Medicare. We need investment in infrastructure for community-based care, not just hospital care, disease management, and population health. And we need equitable funding for physician training in low-income communities. I didn't do a slide on this, but I'm going to tell you that my health system gets paid less for training medical residents than residents get for support in more affluent hospitals that have a better payer mix. And that's because federal GME funding is linked to Medicare and not to Medicaid. So hopefully you've gotten a look at what health inequities look like in one real community. And I'm going to stop here and turn it over to the next speaker, Dr. Vincent Guerrero Ramos.
So good morning. I'm Vincent Guillermo Ramos. Can you guys hear me okay? And I am a nurse. I'm actually glad to break up a little bit of my physician colleagues, kind of shake it up a bit. So I realize I'm in a school of medicine, but we're going to be really inclusive and sort of invite everyone in. So I was asked to speak about the workforce. And so I'm going to share a solutions-focused perspective around some of the challenges that we're facing in terms of our health workforce. Before I do that, I want to start by maybe being very explicit about our use of the term health and healthcare inequities. Inequities are differences, and oftentimes, historically, we've referred to disparities as being differences, but they actually have a very specific characterization that I don't think I've heard so far as part of our discussion. They are preventable, they are unjust, and they are unfair. And they reflect practices in our health system and in policies that result in those unfair, preventable, avoidable differences. I'm going to zoom in on 5 promising solutions that are specific to the healthcare workforce in regards to the elimination of health and healthcare inequities. And you can see them on the slide. The first is redefining the health workforce, scaling up integrated clinical and social care models, addressing arbitrary barriers to practice, thinking through education models that prioritize person-centered care, and then ensuring that our workforce is representative of the populations that are being served. The Ending Unequal Treatment report is just under 400 pages. That's a huge commitment. It was for us. I can imagine if I was on the other side of this podium, I'd be thinking, do I really want to read 400 pages? And I might be debating that. I'll say that just to be politically correct. There is a health affairs forefront piece that's open access. The QR code is on the slide. It's about 3 or 4 pages that summarizes the report and provides some high-level findings, and it might entice those of you that are on the sort of on the edge there as to whether or not you want to make the larger commitment. And so please take a look at that. It sort of reviews the report really well. So I think promising solution number 1 is that we need to redefine how we think about the healthcare workforce. And the spirit here is that if we as a nation are in fact going to eliminate health and healthcare inequities, then we've got to move beyond our traditional workforce of physicians, nurses, nurse practitioners, physician assistants. And we need to expand our workforce. And we need to be prepared to actually include all those members into our integrated teams. That includes pharmacists, that includes mental and behavioral health professionals, particularly addiction professionals. That includes peers and people with lived experiences. And they need to be on equal footing with the actual traditional workforce that we typically define as the health workforce. Very, very important. We know that we've got to scale, so promising solution number 2 is the integration of clinical and social care. And there's been a lot of guidance, certainly our 2024 report, Ending Unequal Treatment, but one of the things that was interesting as the committee was deliberating this particular sort of recommendation, there have been a number of reports that have come out of the National Academies, and just a handful here on the slide. The Future of Nursing report, the Primary Care report, and then a report that's specifically about the integration of social and clinical care. We've got to make sure that clinical care and social care is reimbursed, that it moves beyond the traditional workforce, and that all of those members of the healthcare team, community health workers, peers, addiction professionals, that what they provide is fully recognized and there's a mechanism for payment. I think I've mentioned already the interprofessional care teams. This implies that we don't have a hierarchy, that all members of the team need to work at the highest level of their competencies, their training, in sort of collaboration and connected, but in ways that bring the best of each of us to the care of populations of individuals in need of health. We need new roles. I think that part of the challenge is that we've got to think outside of the box of the way that we normally do things, and how can we identify what needs to get done, who are the people that can do that, and then how will that push all of us to operate in ways that are different than the way that we currently operate. We got to remove, promising solution number 3, arbitrary barriers to practice. We have many places in our country where there are restrictions for non-physician members. It's most pronounced in nursing, but it's not only nursing. It's pharmacy, it's physician assistants. We've got to realize that only together, with all of us operating at the highest level of our competencies, training, and license, are we going to be able to address these inequities. To be perfectly honest, these restrictions reflect turf wars. They're not rooted in science, and they have to do with professional debates that actually are harming our nation, are not helping us to advance. We need to really think through how we can develop interprofessional teams, and training, including in medical schools, should be across disciplines. And I hope that's happening here. I don't want to put anybody on the spot, but prior to being at Hopkins, I was at Duke, and our School of Nursing shared a facility with the School of Medicine, with our PA program, with OT and PT, where we had joint simulation with all the students meeting each other early in their training and working to understand how they could function as a team. Promising solution number 4, we've got to move away from episodic care that is not rooted in whole person perspectives and person-centered, and we've got to get back to some of the basics. How do we make care predictable, relationship-based? How do we bring shared decision-making in? Much more meaningful engagement of communities and families, as opposed to simply focusing on individuals. We've got to really think through how can we address implicit and explicit biases. I've heard today sort of a focus on the individual level, and there was somewhat of a focus on the organizational level. But those biases aren't just in what we do as providers. They're embedded, they're ubiquitous to the actual organizations and the broader policies that shape the way that we provide care. We've got to look at all of that and try to address that in terms of being able to eliminate health and healthcare inequities. And then finally, and probably most troublesome, I've been thinking about this a lot, Rebecca asked us to submit our slides by Wednesday close of business. And on Thursday morning, a number of us from the committee got word that in the Milbank Quarterly, we published a new paper on why the Supreme Court's decision to ban a consideration of race in higher education institutions in regards to admission is bad for our nation's health. I don't have the QR code, but if anybody would like to follow up, I'm happy to send that. It's a great paper, and it basically says that the evidence supports that when we have a representative workforce that is aligned with the populations that are being served, we get better outcomes, better prevention, better treatment, better outcomes. If we're not able to do that, if we're not able to ensure that our workforce is inclusive of the populations that are being served, we will inadvertently contribute to inequities in our nation. In ending unequal treatment, we do review a lot of the evidence for different kinds of training. I would say it's an oversimplification, but I would say that a lot of that evidence is not robust. The kind of training that is the most robust requires ongoing behavioral practice and does not rely on sort of one-offs that are knowledge and awareness, but that really provide providers with ongoing sort of efforts to improve their ability to care for populations that are different than they are. Having said that, educational institutions can do more. We can recruit, obviously, inclusive and diverse faculty that represent the populations that are being served in the community. That will draw a more diverse student body. We must increase targeted funding and pathways for all different kinds of health professionals. And there is in our Milbank Quarterly paper and inside of the report, there is compelling evidence to think about a potential carve out from the Supreme Court of why it's so critical that in the health space that there be an exemption and that we be able to consider the importance of a representative workforce for health in our nation. With that, I'm going to say thank you very much. I'm going to pass it over to the next speaker. Thank you.
Hello, I'm Reggie Tucker-Seeley. Turn on my mic. I'm aging, change my glasses. And I am the principal and owner of Health Equity Strategies and Solutions, a health equity consulting firm that I recently started. Prior to starting this firm, I was on the faculty at the USC Leonard Davis School of Gerontology, and I was also on the faculty at the Harvard T.H. Chan School of Public Health, and my background and training is in public health. And so I was tasked with talking today about this idea that the healthcare system exists within a larger societal system. And we know that, we know that healthcare exists within the larger US society, and it interacts with a much larger societal system that shapes how healthcare is organized, financed, delivered, and accessed, and also influences how and whether the healthcare system is held accountable to achieve optimal and equitable healthcare outcomes for all. I would like to start by posing a question that I started to ask myself at the beginning of the pandemic explicitly. I've been asking myself this question for a while, but during the pandemic, I feel like I got language for this particular question, especially as conversations about health disparities, structural racism, and health equity increased. And that question is, what does an equitable healthcare delivery system look like? We often talk about health equity within the healthcare delivery system. We often talk about intervening in the healthcare delivery system. But what does that system really have to look like to get equitable care? Now, to get an equitable healthcare delivery system, it is imperative that we, and by we, I mean all of us that are engaged in or a part of this system, recognize the following 5 key societal external forces to the healthcare delivery system. One is the structural determinants of health. And these influence the distribution of health-related social needs, our social and economic needs that affect individuals' ability to maintain their health and well-being across different populations to either reinforce or mitigate healthcare inequities. Also, there's oppression and structural racism. And this functions through historical and continued policies such as residential segregation, systematic oppression, and any form of bias harms health through multiple pathways. And these pathways result in adverse physical, social, behavioral, and economic impacts that directly and indirectly affect the healthcare system. There's deprivation of resources and adverse social determinants of health, and these are the conditions in which we live, learn, work, play, worship, and age that affect a wide range of health and functioning and our quality of life. There's also the non-healthcare sector partnerships. And these are the interests of partners outside of the healthcare sector, such as social service agencies, and they can shape priorities and programs of the healthcare system, either positively or negatively, by exacerbating inequities and widening inequity gaps. And finally, it's our commitment to equity, our societal commitment to equity. The societal commitment to identify and remove barriers and create equitable access to resources to achieve equitable opportunities that positively impact health and health care, and the lack thereof reinforce health and healthcare inequities. Now, Healthy People provides a framework for the social determinants of health to identify the mechanisms to create social and physical environments that promote good health. The domains of this framework include the neighborhood and the built environment, health and healthcare, social and community context, education, and economic stability. And we're all familiar with the social determinants of health framework, or most of us are probably familiar with this framework from Healthy People. But what we might not necessarily be familiar with is sort of a greater explication of oppression. And we discussed in the report the 5 faces of oppression. Oppression is defined as a state in which people have unequal power and the process by which dominant groups use that power to subjugate dominated groups. Our committee wanted to ensure that the nuance of oppression was included in this discussion. The discussion of the 5 faces of oppression offers an explication of the concept of oppression. So first, let's think about exploitation. Exploitation enacts a structural relation between social groups where social rules about what work is, who does what for whom, how work is compensated, and the social process by which the results of work are appropriated operate to enact relations of power and inequality. Next is marginalization. And those who are marginalized are people in the system of labor cannot or will not use. In essence, marginalization blocks opportunity. Next is powerlessness. And the powerless have little or no work autonomy. They lack authority and status privilege of the professional class. Next is cultural imperialism. And cultural imperialism involves the universalization of a dominant group's experience and culture, and its establishment as the norm, often without noticing that they do so. The dominant groups project their own experience as a representative of humanity. And lastly is violence. Members of some groups live with the knowledge that they must fear random, unprovoked attacks on their persons or property, which have no motive but to damage, humiliate, or destroy the person. An example, you may be familiar with the Greenwood neighborhood in Tulsa, Oklahoma, which became much more widely known over the past few years, which was known as Black Wall Street in Tulsa, Oklahoma. And surprisingly, I went to college in Tulsa, and I didn't hear about Greenwood until after I'd graduated. We know that multiple factors impact our health behaviors, and how we navigate the healthcare delivery system. However, race and racism have played and continue to play such a significant role in structuring our society that efforts to affect the drivers of health and healthcare inequities without addressing these historical and also contemporary racisms are unlikely to be effective. It's important to note that racism exists at multiple levels. Now, most of us are very familiar with the interpersonal type of racism, that is the one-on-one encounters, but it's also important to consider that racism also sorts us into different neighborhoods and presents barriers to high-quality healthcare. So it exists at multiple levels. It's already been mentioned that there are other reports from the National Academies sort of focusing on healthcare delivery and healthcare equities. And one of the ones that was really critical to our discussion is integrating social care into healthcare delivery. And this report highlighted 5 categories of activities that healthcare systems can use to integrate screening and addressing social determinants of health and social needs. And that is awareness, adjustment, assistance, alignment, and advocacy, where awareness refers to the process of identifying the social needs of the defined patient population. Adjustment refers to the changes that have to be made to clinical care to accommodate the identified social needs. Assistance refers to the strategies employed to connect patients with government and or community resources. And then alignment and advocacy refers to the efforts of the healthcare delivery system to partner with other sectors. Specifically, this is where the healthcare delivery system leverages its resources with the existing social service resources in the community, and where this collaboration works together for additional resources to improve the health of the community. Next, I highlight here a study that was led by Dr. Brina Tara, an emergency physician here in LA County, where the researchers conducted a formative evaluation of social care integration across Los Angeles County Department of Healthcare Services to describe the baseline level of social care integration, to catalog the existing projects, to describe barriers, facilitators, and lessons learned. And this study also introduced a framework for integrating social care. That framework was screen, navigate, connect, address, and evaluate. Now, while several research studies indicate that interventions to address health-related social needs provided in the appropriate setting and depending on the population can indeed improve health outcomes and well-being, a lack of strategy and coordination, as well as the cost of implementation, can hinder the effective integration of social needs into the healthcare delivery system. Next is a focus on non-health sector partnerships and community. Now, we know that organizations that operate outside of the healthcare delivery system can take significant steps towards health equity. However, we also know that there are substantial barriers to these intersectoral collaborations. And Fawcett et al. Presented a framework for facilitating these types of collaborations. We cite this framework in the report. This process is iterative and interactive. The process is systematic and attempts to ensure that all at the table have a voice in developing, implementing, and evaluating the partnership, and that those at the table include members from the community. Lastly, and I think this one is critical, and for this one I'm reminded of a quote that I often use in my own talks about health equity from Sir Jeffrey Vickers on the goals of public health, and this was in a New England Journal of Medicine paper from 1958. The landmark of political, economic, and social history are the moments when some condition passed from the category of the given into the category of the intolerable. We must decide that the disparities that we see, or the inequities that we see in health and health care, are no longer acceptable, that they are indeed intolerable. We can say that we want inequities to be eliminated, but that means that the system must do things differently. How do we get to that equitable healthcare delivery system that I asked about at the beginning? Changes must be made from boardrooms to frontline workers in terms of who is in the room and at the table, to include more members from the communities where healthcare systems sit. While increased awareness about the size and scope of inequities in health and healthcare is important, the political will to address historical wrongs and interrupt the pathways that have been created and sustained by policies that exacerbate inequities, and highlighting that we are all in this together, that is a substantial facilitator to creating health equity. And in conclusion, while it is important to intervene within the healthcare delivery system, we must simultaneously intervene on the larger systems within which the healthcare delivery system is a part. Because, as we cite in the report, many of the factors that contribute to racial and ethnic inequities in healthcare are multi-level and involve societal forces that develop and exist well before individuals enter the healthcare delivery system. Thank you.
Let me start by saying, wow. That was a tremendous set of presentations, and I think it reflects something that I really appreciate about the National Academy of Medicine. When they pull together reports of this type, they do an incredible job of bringing not only people with content expertise, but different lived experience and different perspectives that bring the richness that I think you just heard here today. So fantastic job, everyone. What we're going to do now is dig a little deeper. I have a few questions that I will start to pose to our panel, but you all need to do some work as well, and that is to think about the questions that are foremost on your mind, because we will have a microphone that will go around, and you'll have a chance to ask some questions yourself. So let's make this as interactive and useful to all of you as possible. So maybe I'll just start by saying there's a lot. In fact, I appreciated when the QR code for the Cliff Note version went up and everyone took out their camera. That was really helpful, but maybe can we do that in kind of an audio form as well? There's a lot to address here, and it's not to say that we don't say that to say, oh, it's too much, we're not going to do it. Maybe we could just go down the line and say, you know, what is a key place to start? How would you say, you know, one of the most important things that you take away we need to start to undertake to get this work, continue the ball rolling? Because I think it was acknowledged, progress has been made, but maybe not at the pace or at the scale that has been hoped for. Maybe I'll just start down
Sure.
at your end, Dr. Benjamin, and maybe, yeah, what comes to mind for you of, you know, what's a key priority in terms of what we need to do next? And I'll ask each of you to maybe take that on briefly.
Yeah, I think that to start with, anytime you're bringing up a new program, one of the things you want to do is ask who benefits and who is harmed by the program we're doing, and how are we implementing this? How does it act, you know, today? And as we're trying to evolve programs over time, what are we really trying to do? And I think as part of that, we need to put some metrics in place and measure outcomes and be serious about that, and you know, lock our ideologies outside the room when we do that as part of the process.
Great.
So Andy, I think I wrote 3 things down when you asked the question, so I'll be brief. But I think first and foremost, Dr. Benjamin mentioned this, but this myth of the zero-sum game, this understanding in society that if we focus our efforts on those communities that are experiencing the greatest inequities, that somehow it only benefits them and that other groups lose. Well, in our report, we actually find evidence for the opposite of that. We find that when we target those communities, that in fact they do benefit, but it has benefits for folks outside of those groups that are being targeted. It's also the case, and I want to make sure that I emphasize this, that when we as a nation choose not to address those communities and we are, let's say, complacent in those inequities existing, that it has consequences for those communities, certainly, but it also impacts all of us. I think that's something that's very important. Then just really quickly, Andy, I think the model of care needing to shift from a sick care model that over-prioritizes sort of acute care, episodic delivery of health care. Not that that isn't important and that it isn't needed, but we can do more as a nation in terms of prevention, health promotion, and wellness. And last, that we need to reimagine our workforce in the ways that I described in my presentation that really reflect all of us and that really bring everyone to the table to grapple with what we're facing as a country.
Great. Dr. Batchlor.
Okay, so I'll give 3 responses as well, and I will start with universal insurance coverage and payment reform so that everyone in our society is covered by affordable insurance, and so that that insurance actually means access to quality care when we need it. And I think we need to reform not just what we pay for, but how we pay for. So we need to rebalance the tilt toward hospital and specialty care and get back to a system that is more rooted in prevention and primary care. We need to make sure that we don't have inequities across populations that are covered. Secondly, I'm going to also cite workforce development, but from a slightly different perspective. We need to diversify the workforce so that it looks like the people that are being served. As we were doing research for the study, we found lots of emerging research that shows that people get better quality care from providers who are congruent with their ethnic and racial background. And I think we need to accept that, and we need to diversify our workforce. And then lastly, I'll say, I think we need to routinely stratify our data and measure quality and access, and look across all of the groups that we're serving and hold ourselves accountable for doing the right thing for all of those populations.
Terrific.
Great. So I have 3, maybe 4. So the first thing is being honest with ourselves about the causes of these inequities. I think I recall when I was a student studying public health in the early 2000s, we could not say the word racism when we'd write a paper. We had to dance around the topic, but now we can actually say it. We can say it. So let's be explicit about the causes of these differences. The healthcare delivery system has done great things, but it's also done great harm to many communities, and we have to be honest about that harm because the community remembers. Second is interventions should not just be done within the healthcare delivery system. As we just discussed, the factors that we interact with outside of the healthcare delivery system influence our health just as much, if not more. And so if we're going to do an intervention that is focused on the healthcare delivery system, recognize that then individuals leave that system and have to interact with other systems. So this notion of having intersectoral collaborations, that is, how do we intervene in education, in housing, and healthcare? And then lastly, I was sort of sparked by some of the comments that were made earlier, and what came out during COVID, that is the fact that we didn't have the data to answer many of the questions that we had. So we need better health equity infrastructure to be able to answer the questions that we have about where these differences exist and where best to intervene.
Terrific.
Can I add, that's an example of where focusing on the fact that we had disparities and equities around data, the fact is we still can't move an EKG across the street. That would benefit everybody.
Yep. So, Dr. Benjamin, when you were commenting, I think you got a chuckle from the group because you said, boy, we're really good at doing pilots in this country, but and we're all familiar, even here at KP, about that condition of pilotitis. Tell us, though, when you on the committee looked at the evidence and so forth, was there any examples that did jump out to you of where there was scalable change that was going on in terms of addressing inequities? And I don't know if Dr. Benjamin or anyone would want to speak up to, is there anything in the report that we can go to that would be a powerful anecdote of, here's an example where we did it, what are the lessons there? Were there examples?
Yeah, team-based care. I don't know if you want to.
Yeah, so I guess from my point of view, there are probably a couple of places, Andy. First and foremost, maybe I'll start on the policy level. In the policy chapter of the report, there's clear evidence for the Affordable Care Act. There's also evidence for expansion of Medicaid. There's evidence for sustained efforts that are not one-off. So that would be kind of one thing. A second piece would be the important role of the interprofessional teams, particularly the use of community health workers, where I think there's quite profound evidence, as well as peers, but the integration of those team members into clinical and social care models. There were lots of examples of smaller demonstrations that were sort of beneficial, but not scaled up. I think I'll stop there.
Yeah, states that expanded Medicaid did much better than states that did not expand Medicaid.
Yep.
Not only in overall healthcare outcomes, but also in the inequities.
I think the challenge is that we often are looking at evidence-based programs and practices when we haven't spent the money to do the study to get the evidence for the populations that are experiencing the disparity. So if we don't have the evidence, then does that mean we don't implement the program? And I think recognizing that context matters. And so it's a challenge to, one, sustain programs, but also to scale them up, because we don't necessarily know what does scaling up mean. And so I think in addition to more research, of course, as a former researcher, I know that's always our go-to, we need more research, but also including sort of efforts related to sustainability and scalability to those research studies to really investigate what does it mean to continue this program in this context, but then what does it mean to continue this program in another context with a different population, I think is going to be critical to answering these questions.
Terrific. Great. Well, we're in an educational environment here today, and many of you commented on the importance of looking at our workforce, thinking about education. Dr. Batchlor, you called this out, others called it out. I'm wondering, are there some key takeaways? We have the dean of our medical school sitting here taking notes. What should he hear from this report about how we try to influence education of young people coming in, not just doctors, clearly, because as you said, it's really about a team, but are there particular lessons about things that need to be taught at particular points, or ways of helping to get our emerging health professionals to understand the challenge in front of us and how to take it on in a constructive way? Please.
So I guess I would start by saying that I hope that you will teach your students the full social context that medicine and healthcare occur within, and to understand the social and political determinants of health, as well as the biological determinants of health, so that they can become advocates for the right policies and the right changes in their future careers.
I like that very much. I'll build on that, but I would say the importance of recruiting an inclusive and diverse faculty. That will have direct implications for the student body and what gets reflected in the curriculum. I think there are areas that Dr. Batchlor just mentioned, social determinants of health, but also specific content on the elimination of health and healthcare inequities, specific content on structural and systemic racism, and specific content on meaningful community engagement. Those are areas that often are superficial. I'm not making any statements about this particular fantastic medical school, but I am saying that in general, because the curriculum is so packed with so much that is really around clinical care, that we become a little bit more microscopic than what we need in terms of a broader perspective. I would say also that there's a role for health profession schools around licensing and continuing education, and really helping schools to prioritize what is in fact then later tested on. If it's not tested on, it tends to not be important. And so I think that as much as we can to advocate for that content being essential. Prior to my current role, I was the dean of the Duke University School of Nursing, and I testified regularly in Raleigh about the importance of clinical and social care and why that was really essential to how nurses were trained. And so that kind of advocacy can help people to understand why this content matters.
Fantastic.
Can I add the power of policy? So when I was a state health officer in Maryland, and I was a deputy health officer in Maryland. Deputy health officer runs 80% of the department. We had all the public health programs and all the stuff other than Medicaid. And that also meant we had all the budget hearings. So I went to lots of budget hearings. And most of them, it was me, my budget director, maybe the program officer, the legislator who had to have the hearing, his or her aide, and some legislator or aide who couldn't find some place to have their lunch. And we didn't have anybody else testifying. 80% of the public health budget, $5 billion budget. The rest was all Medicaid. Now the Medicaid hearing, you couldn't get in the room. The room was packed. I would have loved to have people from the healthcare community show up for some of the zoning hearings, to support my public health budget, to support broad public health change that we want to do. Policy is enormously effective at making broad change. If you want to address, you can sit around and try to do cessation therapy all day long. We need cessation therapy for tobacco, but until we get strong anti-tobacco laws on the books, vaping laws on the books, regulate nicotine appropriately, we're not going to make progress on the leading preventable cause of death. If we want to deal with substance misuse, particularly alcoholism in communities, one powerful tool is by reducing liquor store density. And yet again, who shows up at the hearings? Chamber of Commerce, the trade organization for the liquor stores, and people looking for contracts. Health department sitting there waving in the wind. So to the extent that we can teach our students early about the power of policy and get them involved in activism around insisting that these policies get changed, the stronger we'll be.
Amen.
That's fantastic, and certainly I know well aligned with our goals at our school about having future leaders who are able to speak up and not only be champions at the bedside, but also in the policy space. So thank you for that. You know, Dr. Benjamin, in your comments, you pointed out the changing demographics in the country. We're getting older. I'm wondering if, as part of the report, was there any special consideration given to those populations that have been historically marginalized and are now aging? Is there a different way we need to think about these issues of ending unequal treatment, particularly with older population groups, or is it much of the same, strategies we need to think about with others? I just want to recognize and acknowledge that you called out.
We didn't take on aging specifically, but you need to know that that's the tsunami that's sitting outside the door. In fact, it's probably already in the door. The baby boomer generation is aging out. We're losing practitioners and infrastructure at all ages and all levels just because the baby boomer group is going. At the same token, we have not taken on the cost of long-term care. One of the major battles we have in Medicaid every single year, every state legislature is sitting here worried about the Medicaid budget, and they're fighting over pennies around whether they're going to expand coverage for women and children, even single adults. That's not what's driving the Medicaid budget, folks. What's driving the Medicaid budget is long-term care and some of the other specialized populations that we have not taken care of on the front end. So we have a tsunami coming. Monica, we need a study on that. But yeah, we have a tsunami coming on that. But recognize we did look at across the lifespan, and everything we talked about was across the lifespan. But we didn't focus on it well enough to really make any policy-making or significant recommendations.
But Andy, I think your question really highlights the process of creating these types of reports. So this is a snapshot of what's happening sort of in the health equity, health disparities space, and that exists within a larger context of many other disparities that we could have included. And so when you are part of one of these processes, you have to recognize that there's limited real estate in terms of what to include, and there may be some things that some people might think, oh, you left this out or this other important topic out, but that doesn't necessarily mean that it is any less important for the community to address in terms of trying to get towards or closer to health equity.
Yep, great. Hey, I want to acknowledge one of the things I get to do as the Chief Medical Officer is partner with an incredible physician, Dr. Nancy Jin, who's sitting here. And one of the things that Nancy and I do together is to think about what quality measurement can be helpful in our organization to help to address inequities that we may find in our own organization and to continue to play what we want to play as a leadership role for this country to address important issues. Now, you've touched a little bit about the accountability, research, and measurement and so forth, but I'm wondering, any thoughts from you all as panelists about the direction we are seeing? Nancy and I have seen more external regulators and so forth asking to look at data through the lens of equity. We think that's a great thing. We also feel challenges sometimes because how that's defined by different entities can create a little bit of challenges of kind of lining up the data together. Any insights that you all had as a committee or recommendations for us as those that are trying to implement on the ground, so to speak, about quality measurement and how it can be valuable to addressing the important issues you're raising?
Yeah, I would argue that the chief flaw in our data collection system is that we don't collect the data by race, ethnicity, like we should. Even though there's a presidential directive, which we mentioned in our report, to do so, the collection of data by race and ethnicity has been scattershot at best, inconsistent. And I've been one of these folks that believes get the data set that you really need for sure, and then everything else you collect is a bonus. But it's also not just because people don't want to collect it, and there are some resistance to collecting the data. Lots of excuses are made. But the system isn't designed to do so. You know, right now, for example, on hospital billing forms, there's no race and ethnicity. There's a spot there that they could put race and ethnicity on there, but they don't. So the insurance companies and the billers don't have a sense of what's happening for populations that they're dealing with. And there's been a group of us trying to get that to happen and encourage CMS to require that. But we're not collecting the data in a systematic way and then reporting it. That was the fundamental problem with COVID. It wasn't that CDC was sitting on the data. CDC was struggling to get the data. And of course, our public health system, which used the most modern of communications tools called the fax machine. You know, once a piece of paper goes handwritten, and we're still writing things by hand, and you folks here in California, I think, know what I'm talking about. And you put it through the fax machine, and it gets adjudicated 4 people down the line, trying to figure out race, ethnicity, even gender sometimes, if that bucket is empty, is a lot of work.
Yep, great. All right, now it's your turn. I want to see some hands up. We have Rebecca here with a microphone. What kind of questions or comments would you have for our panelists? Looks like Paul has his hand up, and we have a few hands up. Okay, all right, terrific. Please state your name and your role. Yep.
Brian Mittman, scientist right next door, Kaiser Permanente, Department of Research and Evaluation. I want to challenge the argument that I believe you said is in the Health Affairs article that we need a carve-out or an exemption from the Supreme Court prohibition on using race. I think we'd like to have that, but I also think that it's unlikely to happen. So the question is, what are the alternatives? What's Plan B? And I think there is a Plan B that's directly in the evidence that you stated at the beginning of the statement. That is that high-quality physicians are those who, in part, can relate to and obtain a better diagnosis, achieve higher rates of adherence. So the question is why medical schools can't complement test scores, grades, as predictors of success with some of these other factors that include your ability to relate to your patients. So I think the broader principle is when we issue recommendations of this sort, we take a second step back to think about the feasibility of those recommendations. And when we have a recommendation that we suspect is not likely to be successful in our lifetimes, or at least in the short term, we see if we can think creatively about some backup. So is that an option that you would consider? Is that an option for those who are in medical school leadership positions that is feasible to take into account those other factors?
Yes, life experience is actually something you can add as part of that process. But the most important thing you need to do? Get out of the building and go out in the street and find some of them. Because I'm always hearing, can't find any. And that's one thing that you have to do. The second thing is we have to do a better job at the number of African American physicians who have been very successful, who were told that you'll never be accomplished and you'll never get into medical school, is astounding to me. Many of us have had that experience in life. And so we need to get counselors out there who are going to beat the bushes and find these students who have the ability to go to medical school.
So just to build on the response, and sorry, I just want to respond to questions. The first thing is that the paper is in Milbank Quarterly, not in Health Affairs. And so it just came out on Thursday. And so if anyone would like the link, I'm happy to provide that. It's open access. On the committee were legal scholars as well, and so they were involved in the publishing of that paper. And there are a set of recommendations, many of which you identified, so thank you very much, that look at sort of what health profession schools can do, what sort of government can do that are sort of realistic within the confines that we have, but also go one step further in imagining what a carve-out might look like. And there's some evidence for that because it's happened with the military. And so I think that our task was to think of the multi-pronged approaches and all of the pathways. I'm not suggesting that we not do the things that we just heard from Dr. Benjamin and yourself, but we looked at all of those things. Thank you.
Dr. Batchlor.
I'm going to push back a little bit because we did review the research, and there is an increasingly emergent body of research that shows that qualified physicians treat their patients differently depending on the ethnic background of the physician and the patient. We also looked at evidence that bias training works, and there's a lack of evidence to support that as being effective. And I think that is one of the reasons that we did come to the conclusion that we need to diversify the workforce, and we need to search for legal avenues to do that. So I'm going to push back on you a little bit and say that I don't think that simply training qualified physicians is enough to reverse those biases and discrimination.
Sure, no, I didn't mean to state that we don't need diversity. I was offering a recommendation for a strategy to achieve it during the period in which we can't get that carve out. But the goal is the same. It's just a different strategy to get there.
Thank you. Who else has a question? Again, introduce yourself. Great.
Hi, I'm Paul Chung. I'm the general pediatrician. I'm the chair of the Health System Science Department here at the school. Thank you so much. This was genuinely just awesome, and I so appreciate everyone for hosting the event here, and also for you joining us and teaching us. So I'm gratified to hear that, to say that everything, or almost everything that you presented today is actually already a part of our core curriculum in health system science here. And so that's been great. And I don't think we're alone. I mean, I actually think we're just one of several, and maybe even one of many schools at this point who are really trying hard to figure out how to do right by our students and do right by the communities that we serve by teaching this and putting this throughout the 4 years of education. I struggle with this because I on some days I feel pretty good, and on other days I'm thinking, wow, this is not enough. It's not anywhere close to enough. It's a tiny drop in the bucket. And I think part of what bugs me on those days is this, which is that I think a lot of the presentations were spent on sort of complex, big solutions to big problems, which is absolutely necessary. Mm-hmm. And we can teach about that. And I think we can also teach about small-scale individual solutions to small-scale individual problems. Mm-hmm. But I think what the students hunger for, and what we really struggle to teach, is how to bridge the two, right? To get from small scale to big scale, to get from big scale to small scale. And I think you were pointing out a lot of struggles too. You were talking about programs, about pilots, about sustainability and scale. And I'm just wondering, there's a whole continuum of education that starts before medical school, but includes medical school and then goes all the way through residency, fellowship, through continuing education. How do we, across this span of years, how do we get students to think about that and to learn about that middle zone of programs and small policies and scale and sustainability in really constructive, concrete ways that will actually help make things better?
I've always argued that there are several things that we have failed to do, in our society. We've taken all the social sciences out of early education. A lot of the humanity out of these kids' education. I mean, reading, writing, arithmetic is fun and it's interesting, but I'm a science nerd. We took civics out. So most of them don't have a clue how a bill gets made or how the world, how the trains run in the real world. So I think one of the things we've got to do is very deliberately give these kids the experiences that they need, and so that they understand that there are many, many kids in our communities that have no clue of what the world is like within a 5 or 6 block radius of where they live. And that's their universe. And that's why those kids who live in those communities which are distressed, never, they don't know anyone who's lived beyond the age of 21. And so they can't conceive of a long life. They think we're unusual. Somehow we're special, having gotten away and got into these jobs. And so we've got to do a better job of building a future and these kids and some hopelessness, and get rid of this helplessness that they have. But that requires a lot of rolling up your sleeves and getting the communities early on and doing the real work.
I chuckled at your question because I think if we can solve that, then yes, we will have achieved health equity. I think I'm recalling being a grad student and taking multi-level statistical methods, and so I think we have really great statistical tools for evaluating things at multiple levels. But I think outside of those models, we struggle with really thinking about the processes that led to the interactions across levels. We can do sort of X variable times another variable, but what is the process? So not necessarily always focusing on the outcome, but in addition to the outcome, what are the processes that led to these interactions that we are putting into these very complex statistical models? We don't normally talk about those things. And there was a period when complex systems was really hot in public health. And we're really good, again, at being sort of on a topic that's really hot and we'll fund it, and then we get bored with it, and then we move on. And so I think maybe going back to some of the notions from complex systems might be helpful as well, to really help us to think about, if we make a change in one part of the system, it's going to impact another part of the system, and really diving deep into those topics and not just sort of hanging on to them while they're sexy and we can get a big NIH grant and then we move on because it's no longer popular.
Okay, we're just about at time, so in the lightning round, a takeaway sentence. What do you want this group, what do you want the broader audience who will see this to take away from your report? Read 400 pages, is that the message? What's the take home? Reggie, starting with you, and we'll go down that end.
That healthcare exists in a larger societal system.
Great. Elaine?
We can reverse health inequities.
Great.
We have many tools, both programmatically at the policy level, that if we scale them up, they can have a big impact on health.
Great.
The system's designed to give us poor outcomes.
Okay. Well, with that, thank you very much to this incredible panel. Jesse, close us out. Great job, folks.
Thank you, everybody, for joining us today. I would like to thank the staff, of both staff of the KP School of Medicine, our colleagues at the National Academies. Thank you so much for your support. To our esteemed speakers, we really appreciate you traveling and bringing your perspective here to us today. We have a forum advisory group and a steering committee that we work with that gave their input and advice and guidance as we prepared for today. So I'd like to thank all of them. I would like to also thank Maryland and Wendy, who help with our event management support, everyone at the KP School of Medicine who helped make this possible, Spark Street Digital, our colleagues with support for our audio video today, to Enos Casey as well for photography. And to all of you for joining us. Honestly, the conversation was really, really important and too short, I believe. But before you leave, could you please take a few minutes to complete the event survey? You can access that through the QR code that was provided and there at the bottom of the slide there. We do listen to all the information that we get from those surveys, and it can help us make our next event better. All the forum materials and the links to the full recording of this event are going to be available in about a week. And so for now, that concludes our event. I want to thank all of you for joining us, and again to the School of Medicine for hosting all of us. And we hope to see you at a future event soon. Thank you.
So we just wanted to do two quick things just to wrap up. One, to say thank you to the School of Medicine, particularly the dean and the faculty. Paul, your comment was spot on. It's really comforting to know that at this particular medical school that work is happening, and let's hope that it happens across more health professions. And then also, we just want, is Francis in the audience somewhere? Where's Francis? Francis, stand up for a second. You got to stand up. Our study director from the Ending Unequal Treatment report. We've got to acknowledge Francis, so thank you. And Cheryl as well. Cheryl, if you could also stand up, thank you. Thank you, Suzanne.